Hello, everyone. Welcome to another exciting edition of Haematology and Blood Transfusion Science Lecture Series, a YouTube channel where we discuss different topics in hematology and blood transfusion science. Thank you for subscribing to our channel. Thank you for being part of what we are doing, for sending in your questions and your feedback. They have been very, very useful to us. And if you have not subscribed yet, this is the time to hit the button. Please hit the subscribe button now. And if you want to contact us, use our email. It is on the screen, scholarlywoman20 at gmail.com. Thank you. My name is Dr. Ifeoma Mary Ann Okafo, and today we are going to be discussing another exciting topic tagged neonatal hematology and laboratory investigation of associated disorders. Trust me, you're going to learn a lot from it. Let us go straight to today's lecture. Thank you. Learning objectives. It is expected that at the end of this lecture, you should be able to identify and classify common hematologic disorders in neonates and infants. You should also be able to understand the pathophysiology and clinical implication of neonatal hematological abnormalities. Differentiate the key physiological and hematological parameters in neonates and infants from those in older children and adults. You should be able to outline the essential laboratory investigations for the diagnosis and monitoring of neonatal and infant hematological disorders. You should be able to apply the knowledge of reference intervals in neonatal hematology to access laboratory results accurately and critically evaluate the unique challenges and potential pitfalls in collecting and analyzing blood samples from neonates and infants. Hematological parameters in neonates and infants differ significantly from those in adults. This is actually due to a shift from fetal erythropoiesis, which primarily occurs in the liver and the spleen, to that of adult erythropoiesis, which occurs in the bone marrow. We have done a detailed lecture on erythropoiesis, different stages of erythropoiesis, and different sites where hemopoiesis takes place. Please, if you want to know more about erythropoiesis, hemopoiesis, please click on the link that is showing on the slide, and then you can watch the lecture video in full. The transition from fetal erythropoiesis to adult erythropoiesis is marked by a change in hemoglobin type and a gradual maturation of the hematopoietic system. Hematological system in the neonates is a dynamic evolving event with unique physiology. It has unique reference ranges and a distinct set of pathological challenges, which we are going to look into today. The fetal and neonatal environment is relatively hypoxic, and this drives hematopoiesis. At birth, major physiological shifts occur. When a baby is born at birth, there is a major physiological shift. Normal developmental hematology in neonates and infants. Let us have an overview of hematopoiesis and developmental regulation, because just as I said before, we have a detailed lecture on this. You can click on the link and watch it in detail. Early in gestation, hematopoiesis begins in the yolk sac, and we have hemoglobins that are responsible for carrying oxygen to the tissue. In the yolk sac, it is hemoglobin GOA 1, GOA 2, and hemoglobin Portland. Now, from yolk sac, it then shifts to fetal liver, and then spleen, and later to bone marrow. In the neonates, residual extramedullary hematopoiesis may persist. Growth factor, niche factor, stem cell kinetics differ from that of an adult. Immune system development is still immature. They don't have neutrophil reserve. Complement level and immunoglobulin production are actually limited in the neonates. Fetal hemoglobin predominates in neonates at birth, and this fetal hemoglobin has higher oxygen affinity. It fluences oxygen delivery to the tissue, and the hemoglobin oxygen dissociation curve. At birth, within the first 6 months, there is a gradual replacement of fetal hemoglobin by adult hemoglobin, which is hemoglobin A. There is what we call physiological anemia of infants. In the first few months, hemoglobin and hematocrit decline. This is due to decreased erythropoietin stimulus, increased red cell mass dilution, and then shorter red blood cell span. The red blood cell has shorter lifespan in the neonates. This is more evident in premature babies. In preterm infants, especially, anemia of prematurity is common. The features are normocytic, normochromic, and often hypoproliferative. There is low reticulocyte count because the bone marrow is unable to support the demand. Note that neonates have a high red blood cell count at birth, high hemoglobin level, and also high hematocrit. But these rapidly decline over the first 2-3 months after birth. This physiological drop is what we call physiological anemia of the newborn. The rapid decline of the red cell count, hemoglobin, and hematocrit after the first 2 to 3 months of birth is what is termed physiological anemia of the newborn. At birth, hemoglobin can be as high as 14 gram per dl to 22 gram per dl, and this is due to high erythropoietin level in the uterus. It then falls to between 9.0 gram per dl to 11.0 gram per dl at about 8 to 12 weeks after birth. As oxygen availability increases and erythropoietin production transiently decreases, red blood cell lifespan in neonate is shorter, between 60 to 90 days, compared to that of an adult that has 120 days. This actually adds to predisposing them to anemia. Iron stores, erythropoietin response, and iron metabolism in neonates also differ. Important things to note. Number one, in neonates, gestational age matters. A preterm infant will have different values from a full-term infant. Again, postnatal age is also very, very crucial. Values change dramatically in the first hours after birth, even in days and also in weeks and months of life. The sample size is also very, very important. Capillary samples like heel prick can yield slightly higher hemoglobin and hematocrit compared to venous samples. This table is showing us the normal values for a full-term neonate between 38 to 40 weeks gestation. You should know that the most significant changes occur in the first 24 to 48 hours of birth. Let us take the first parameter, hemoglobin. At birth, that is cord blood, hemoglobin level is between 13.5 to 20 gram per dl. At 24 hours of birth, there is an increase to about 14 to 23 gram per dl. Then 1 week later, at 1 week of age, there is a drop to about 13 to 21.5 gram per dl. And then 2 weeks of age, there's a further drop in hemoglobin to about 12.5 to 20.5 gram per dl. While at 1 month after birth, you have a further drop in hemoglobin level to about 10 gram per dl to 18.0 gram per dl. The neonates have macrocytic red blood cells. So the MCV at birth is between 100 to 120 femtoliter. Within 24 hours, we have a slight drop to about 95 to 118 femtoliter. At 1 week of age, you have the MCV coming down to between 88 to 110 femtoliter. At 2 weeks of age, you have it further drop to about 86 to 108 femtoliter, while at 1 month of age, you have another drop to about 85 to 108 femtoliter. MCH also undergoes also sharp drop from 31 to 37 picogram at birth to about 28 to 34 picogram after 1 month of birth. The same thing with MCHC. And then reticulocyte at birth, you're having a high reticulocyte count of about 3 to 7%. Then 1 month later, it comes down to about 0.5 to 2%. Looking at that table that we just showed now, there are key physiological events that you should note. Number one, a rise in hemoglobin at 24 hours. This occurs due to a shift of plasma water from the intravascular to the extravascular space after birth, leading to hemoconcentration. The second one is fall in hemoglobin level, what we call physiological anemia. After the first week, hemoglobin gradually declines, reaching a nadir of about 9 gram per dl to 11 gram per dl at 8 to 12 weeks of age. This is a normal process due to shorter lifespan of the fetal red blood cells, which is between 60 to 90 days versus 120 days that you have in adults. Rapid growth and expansion of blood volume that is normally associated with neonates. Suppression of erythropoietin production due to high oxygen saturation after birth. There is also a change in MCV. The MCV is markedly high. The MCV of infants is actually between 100 to 120 femtoliter. And this is due to the presence of large macrocytic fetal red blood cells. This is a key differentiator from adult macrocytic anemia. Then reticulocyte count. There is elevated reticulocyte count at birth, having as high as between 3 to 7%. And then this falls rapidly within the first week. A persistently high reticulocyte count after the first week is pathological and suggests hemolysis or blood loss in the neonates. This second table is showing us the normal values for infants beyond the neonatal period. And then we have the first one, hemoglobin. At the age of 2 months, we had the hemoglobin value being normal between 9 gram per dl to 13 gram per dl. Between 3 months to 6 months, we have the normal range at between 9.5 gram per dl to 13.5 gram per dl. Then between 6 months to 2 years, you will have the normal value of hemoglobin in the infant between 10.5 gram per dl to 14 gram per dl. Mean cell volume at 2 months, you will have the normal value between 77 to 101 femtoliter. At 3 to 6 months, 74 to 96 femtoliter. At 6 months to 2 years, you have 70 to 85 femtoliter. 2 years to 6 years, you can have the MCV being normal between 73 to 87 femtoliter. The key takeaway from the table that we have just looked at is that number one, the MCV is at its lowest point between 6 months and 2 years of age. This is often called physiological nadir of mean cell volume, and it is due to the production of smaller red blood cells and a relative dilutional effect of rapid growth that is normally associated with infants. It is very, very important not to over-investigate a slightly lower MCV, that is MCV between 70 to 75 femtoliter, in an otherwise well non-anemic infant that is within this age group. According to WHO, the threshold for diagnosis of anemia in the infants are number one, the term neonates, that is Neonate between 0 to 28 days. Anemia is diagnosed when the hemoglobin level falls below 14.5 grams per dl. For infants between 1 to 6 months, anemia is diagnosed when the hemoglobin level falls below 10.0 gram per dl. While for infants between 6 to 59 months, that is 5 years, anemia is diagnosed when the hemoglobin level falls below 11 gram per dl. Clinical assessment is very vital in defining anemia in neonates. A hemoglobin level of 14 gram per dl in a 1-day-old is normal, but the same value in a 2-week-old may warrant investigation depending on the clinical context. Let us now consider white blood cell count in the neonates. Neonatal neutrophil counts undergo dynamic changes too. There is a physiologic neutrophilia in the neonates, followed by a decline. The normal neutrophil count vary by hour of life. Reference intervals are age-dependent. Neonates have limited neutrophil reserves, that is, they have limited marginated pool and limited marrow reserve also. And hence, they may decompensate easily. That is, they can have neutropenia easily, especially in sepsis or maternal immunologic conditions. Lymphocyte subpopulations, monocytes, eosinophils, basophils are present, but in a limited functional capacity, like because they are still immature. Example, their function like hemotaxis or oxidative box are actually limited in neonates because they are relatively immature. Newborns typically have a higher total white cell count, that is between 10 to 25 times 10 raised to the power 9 per liter, with a predominance of neutrophils. This count gradually decreases over the first few days of life, with a shift to lymphocyte predominance by around 1 week of age. You need to note that newborns typically have a higher total white cell count. So high total white cell count in the newborn is normal. The range is actually between 10 to 25 times 10 raised to the power 9 per liter. And the predominant white cell at this stage is neutrophils. Neutrophils are predominant, but this high level of neutrophils at birth gradually decreases over the first few days of life, with a shift to lymphocyte being predominant by around 1 week of age. When considering white cell counts in the neonates and infants, there are key things to note. Number one, what we call physiological leukocytosis. Neonates have a higher WBC count, which peaks in the first 12 to 24 hours of life. This is a normal physiological response to the stress of birth. It is not abnormal. Number two, rapid changes. There is a rapid change in WBC count and differential. That is a dramatic change in the first few weeks. And this change continues to evolve throughout infancy. Number three, there is danger signs. Neutropenia is the major red flag for sepsis in the neonates. A rapid falling in WBC count or a left shift, that is increased presence of bound form or immature forms in the peripheral blood film, is also highly suspicious of infection in the neonates. There is lymphocyte predominance. At the end of first week, lymphocyte becomes the predominant WBC, a pattern that continues until about 4 to 6 years of age. This is what we call lymphocyte crossover. This table shows us the total white blood cell count and absolute neutrophil count in the neonates and infants. It is good to know that the absolute neutrophil count is the most critical parameter for assessing infection risk in the neonates and infants. And how do you calculate absolute neutrophil count. It is total WBC count times the percentage neutrophil count plus percentage bound form. From the table, you can have that at bed, that is cord blood. The total white cell count is between 9.0 to 30 times 10 raised to the power 9 per liter. The absolute neutrophil count is about 2 to 11, while between 12 to 24 hours, there is a sharp increase to about 13.0 to 38.0 times 10 raised to the power 9, while the absolute neutrophil count rises to about 7.0 to 26. At 1 week of age, you have total white cell count dropping to about between 5 to 21.0, while the absolute neutrophil count drops drastically to about 1.5 to 10.0. At about 6 months of birth, you have the total white cell count increasing to about 6.0 to 17.5, while the absolute neutrophil count comes down to about 1.0 to about 8.5. This table is showing us the normal differential WBC count, that is absolute values in neonates and infants. The table provides a more detailed breakdown of the major leukocyte lineages. The key takeaway from this table is that the lymphocyte crossover occurs between the first and second week of life. After this point, lymphocytes outnumber neutrophils until the child is about 4 to 6 years of age. This is the opposite of the adult pattern. Critical values, values that can trigger immediate concern and action. Number one, neonatal neutropenia. This is a hematological emergency as it signifies high risk for severe infection. Maternal neutropenia, the possible causes are: number one, maternal hypertension. Example, preeclampsia, HELP syndrome. HELP syndrome is presence of hemolysis, elevated liver enzymes, and low platelets in the pregnant woman. Prenatal or neonatal sepsis, especially bacteria, can give rise to neonatal neutropenia. Alloimmune neonatal neutropenia, congenital infections like CMV, rubella. Leukocytosis with a left shift is a red flag in neonates. Studies have shown that a high WBC count is less specific than neutropenia in assessing infection risk. But presence of a left shift is a powerful indicator of bacterial infection, even if the total WBC count is normal. Platelet count in neonates. Platelet count and lifespan in neonates are actually similar to older children and adults. The normal range is still between 150 to 450 times 10 raised to the power 9 per liter, just as seen in an adult. But platelet counts in healthy neonates can be slightly lower, especially in preterm infants. Neonatal megakaryopoiesis is sensitive to stress, and many neonates in neonatal intensive care unit develop thrombocytopenia. Thrombocytopenia is always a pathological condition in neonates and should be investigated. Neonatal coagulation system. Neonatal coagulation system, that is the hemostatic system in the neonates, is a balanced system with reduced reserve. It is often described as a mild physiological coagulopathy. Vitamin K dependent factors like factor 2, factor 7, factor 9, and factor 10 are significantly reduced in the neonate to approximately 50% of that of an adult. Due to hepatic immaturity and a sterile gut, no vitamin K producing bacteria is found in neonates, and you know that their liver is also immature. Contact factors like factor 11, factor 12, and others are low, leading to a prolonged activated partial thromboplastin time that does not correlate with bleeding risk in the neonates. You should also note that neonates have lower prothrombin concentration and lower capacity to generate thrombin, contributing to a lower baseline in coagulation access. Fibrinogen. Fibrinogen is functional but may be present at lower concentrations too in the neonate. Natural anticoagulants like protein C, protein S, and antithrombin are reduced in the neonate. Interpretation of this is that prothrombin time test is a more reliable indicator for coagulation status than activated partial thromboplastin time test in the newborn. In the neonate, the balance between bleeding and thrombosis is very, very delicate. Neonates are at risk of both hemorrhagic and thrombotic complications, particularly those that are in neonatal intensive care unit setting. Now, let us have a closer look at the laboratory investigation of common neonatal disorders. Number one, that we're going to look at what we call physiological anemia of the newborn. Physiological anemia of the newborn. This is normal. It is non-pathological decline in hemoglobin level due to a combination of decreased erythropoietin production in response to improved tissue oxygenation and the shorter lifespan of the fetal red blood cells. It is usually asymptomatic and does not require treatment. Polycythemia in the infant or hyperviscosity. The neonatal polycythemia is typically defined as hematocrit level that is above 65% or 0.65 liter per liter in a term infant. Definitions may vary in different centers, but commonly it is defined as hematocrit level that is above 65% in a term infant. Causes include maternal diabetes, intrauterine growth restrictions, delayed cord clamping, twin transfusion, intrauterine hypoxia. Clinical features might include plethoric appearances, hypoglycemia, respiratory distress in the neonate, feeding difficulties, hyperviscosity, which can lead to seizures or lethargy. Management may include partial exchange transfusion in severe cases. Another condition that is common in neonates is hemolytic disease of the fetus and the newborn. Again, we have done extensive lecture on hemolytic disease of the fetus and the newborn, and the link is on top of this slide. If you want to have a detailed knowledge of hemolytic disease of the fetus and the newborn, please click on the link so that you can watch the lecture video and learn more. An overview of pathophysiology of hemolytic disease of the newborn. Maternal immunoglobulin G antibody crosses placenta and attaches itself on the fetal red blood cells, synthesizing the fetal red blood cells, and these fetal red blood cells are destroyed prematurely. Common causes are blood group incompatibilities between the child and the mother, and the antibody that are mostly implicated are anti-big D, anti-little c, and anti-kel antibodies. And we have clinical presentation. They have spectrum of severe hydros fetalis, anemic heart failure, and then you can also have mild jaundice depending on the antibody that is involved. Laboratory investigation include doing direct antiglobulin test on the baby red blood cell, then indirect cum test on the mother. Positive direct cum test confirms antibody-coated red blood cells. You can also do full blood count to ascertain anemia, elevated reticulocyte, nucleated red blood cells by the time you look at the peripheral blood film. Examination of peripheral blood film will also help you to diagnose hemolysis, evidence of spherocyte, especially in ABO incompatibility. Some clinical chemistry tests that can be done include bilirubin assay, total bilirubin, both conjugated and unconjugated. Presence of increased unconjugated bilirubin gives an indication that hemolysis is going on, that red cells are being destroyed at a faster rate than the liver can conjugate. Then there is identification of antibody. An antibody identification test should be done to identify the antibody that is actually destroying the baby's red blood cell. Again, I have done a detailed lecture on antibody screening and antibody identification. I'm going to put the link on this video and you can click on it and learn more about antibody identification. Hereditary hemolytic anemias. These often present with persistent or severe jaundice after few days of life. It can be as a result of red blood cell membrane defects. Example, in cases of hereditary spherocytosis, it can also be as a result of enzyme defects. Clinically, it is presented as jaundice, pallor, splenomegaly, and then when you are doing the laboratory test we normally do in the lab. Of course, full blood counts. The full blood count will look at the red cell parameters, WBC parameter, even platelet parameters, and then you look at your blood film. The blood film will show you the evidence of spherocytes, poikilocytosis, that's a different shape of red blood cells, and the predominant shape that will be present are spherocytes in hereditary spherocytosis. You have anemia, high MCHC, high red cell distribution width, and then, of course, spherocyte. Confirmatory tests include osmotic fragility test or eosin 5 melamine binding test, which is actually more specific. Red cell enzyme deficiencies. Example is G6PD deficiency or pyruvate kinase deficiency. Clinically, it can cause acute hemolytic crisis triggered by oxidative stress, infection, certain drugs, or naphthalene in mothballs. Importantly, it can present with severe neonatal jaundice even without an obvious trigger. Laboratory test is we can do full blood counts and film reading. Anemia will be present, reticulocytosis will be present, and can you have bite cells and Hess bodies, which can also be present in supravital stem. Confirmatory test, you can do the G6PD enzyme assay. Caution, false normal result can occur during a hemolytic crisis due to high reticulocyte count. Repeat testing is necessary to actually confirm whether it is a G6PD deficiency. We have another disorder that can occur in neonates, congenital red cell aplastic anemia. These are rare conditions, with the most notable being diamond blackfan anemia, an inherited disorder of erythropoiesis characterized by a failure to produce red blood cells. It presents with severe macrocytic anemia in the infancy. Another disorder that can occur in the neonates is neutropenia, leukopenia, and functional neutrophilia. Neutropenia in neonates may occur secondary to sepsis, maternal hypertension, isoimmune neutropenia, bone marrow suppression, or congenital neutropenias. Because neonates have limited reserve, even mild neutropenia is more clinically significant. Laboratory workup include doing absolute neutrophil count, serial monitoring, bone marrow evaluation, functional assay that will do oxidative bursts and chemotaxis if indicated or if needed. Thrombocytopenia and platelet disorders. Neonatal thrombocytopenia, which is secondary thrombocytopenia, is common mostly in neonates that are in intensive care units, especially in preterm infants. Causes may include sepsis, necrotizing enterocolitis, which is NEC, disseminated intravascular coagulation, maternal conditions, autoimmune ITP, perinatal asphyxia, congenital infection, and bone marrow failure. Neonatal alloimmune thrombocytopenia. Neonatal alloimmune thrombocytopenia occurs as a result of maternal antibody crossing the placenta and attacking fetal platelets, leading to fetal platelet destruction. It is one of the most common causes of severe thrombocytopenia in term infants and the leading cause of intracranial hemorrhage in affected neonates. And I have another congenital thrombocytopenias, which are rare inherited platelet disorders. Diagnostic approach: platelet counts is done, evaluation of the bleeding, maternal history, platelet antigen testing, possible human platelet antigen. Bleeding disorders: neonates are at risk of bleeding, especially intracranial hemorrhage in preterms, vitamin K deficiency bleeding, DIC as a result of sepsis or asphyxia, and then congenital factor deficiencies. Thrombosis. Thrombosis is increasingly being appreciated in neonates, often associated with central venous lines, sepsis, dehydration, and congenital thrombophilia. Hemostatic derangement in neonates must be interpreted cautiously due to developmental differences in coagulation factors. Vitamin K deficiency bleeding, VKDB, formerly known as hemorrhagic disease of the newborn. It occurs classically between day 1 to day 7 of birth, and this is due to inadequate vitamin K prophylaxis, presence with GI bleeding, bruising. It occurs late at about 1 to 12 weeks, often in exclusively breastfed infants who did not receive prophylaxis. High risk of intracranial hemorrhage can occur in these children concerned. Laboratory investigation include coagulation screen, doing prolonged PT, which is the most sensitive marker to assay vitamin K deficiency bleeding in children. Presence of prolonged PT, prothrombin time test, prolonged APTT, and normal fibrinogen, and then platelet count should also be done. Another disorder is inherited coagulation factor deficiencies. Inherited coagulation factor deficiencies. Hemophilia A and B, like absence of factor 8 and factor 9, that is, factor 8 and factor 9 deficiencies can be present, and they can present with intracranial hemorrhage, prolonged bleeding after circumcision, or large Kepha hematomas. APTT is prolonged. Specific factor assay confirm the diagnosis, and specific factor assay include assaying for factor 8 or factor 9. Then we have factor 13 deficiency. Factor 13 deficiency in children presents with umbilical stump bleeding. Screening tests like PT and APTT are normal. Diagnosis requires a specific factor 13 assay or clot solubility test. Another disorder is neonatal sepsis, and laboratory findings include neutropenia or neutrophilia with a profound left shift, toxic granulation. Thrombocytopenia is a common and ominous sign, and elevated C-reactive protein. Congenital leukemias. Congenital leukemias are rare but critical, and they present with hepatosplenomegaly, skin nodules, and a high WBC count. Laboratory findings include full blood count shows blast. Key differential is congenital infection, example, CMV rubella, which can also cause leukomoid reaction with circulating immature cells. Flow cytometry and cytogenetics can help to diagnose the disease. Hemophagocytic lymphohistiocytosis, HLH. This is a life-threatening hyperinflammatory syndrome that can be familial or triggered by infection. Example, EBV and CMV. Pre-analytical consideration and specimen handling. What do you do when you are collecting blood, or the things you do when you collect sample from a neonate? Venous access. Obtaining a blood sample can be very difficult in neonates due to the small size of the vein. Blood volume that is required should be small, and blood is precious in neonates. Therefore, you should minimize phlebotomy and use micro techniques. Neonates and infants have a very small total blood volume. Therefore, care must be taken to avoid iatrogenic anemia. Then sample quality is very, very important. Samples from heel prick or finger pricks can be subject to hemolysis and contamination with tissue fluid, which can affect the accuracy of the result. Hemolysis, clotting or dilution artifacts are more common in sample collected from that site, from heel prick and finger prick, and careful technique and prompt processing are critical. Capillary samples may have increased platelet count or WBC differential biases. Appropriate anticoagulant ratio for small volumes in collecting sample from neonates. Appropriate anticoagulant ratio must be applied. In addition to sample quality, the temperature, the transport mechanism, and time of analysis matter a lot more in neonates because of labile cell populations. Laboratory reference ranges using adult reference ranges can lead to misinterpretation of results. It is crucial to use age-specific and institutional-specific ranges interpreting results that has to do with neonates and infants. Protein tests in neonates include complete blood count, what we call full blood count, which includes red blood cell indices, white blood cell counts and differentials, and then platelet count, and assessing platelet, white cell morphology, platelet morphology, and red blood cell morphology. Reticulocyte count, which may include absolute reticulocyte count and also calculation of reticulocyte production index. Peripheral blood film morphology examination that will help us to look at identifying poikilocytes, macrocytes, anisocytes, and blasts. Direct antiglobulin test or cum test for suspected hemolysis of immunologic origin. Then bilirubin profile tests that include total bilirubin, direct or indirect, then lactate dehydrogenase assay, haptoglobin test, unconjugated bilirubin estimation, serum iron studies, ferritin, TIBC in suspected iron deficiency, and then blood group typing, which is essential for both the infant and the mother to investigate potential blood group incompatibility. Hemoglobin electrophoresis or high performance liquid chromatography that can be used to detect hemoglobin variants. Then enzyme assay or molecular testing that can be done to identify G6PD deficiencies or pyruvate kinase deficiency. Then we have bone marrow aspirate or biopsy can be indicated pancytopenia or bone marrow failure. Then platelet antibody testing, platelet antigen assay that is involved in human platelet antigen typing that is help to identify thrombocytopenia or immune thrombocytopenias. Coagulation panel, doing coagulation panel like PT, APTT, fibrinogen, thrombin, D-dimer, factor assay if available and if needed. Functional hemostatic test can also be done. Neutrophil functional assay can also be done. And then we have advanced or specialized tests of molecular diagnostics, flow cytometry, genetic and molecular testing, next generation sequencing for hemoglobinopathies, congenital bone marrow failure syndromes, platelet function tests, chromosome karyotyping, and thrombophilia workup can also be done where they are needed. You should have these few takeaways from this lecture today. Number one, neonates are polycythemic and macrocytic. Neonates have very high hemoglobin and very high MCV at birth, and this is normal. Number two, the what we call hemoglobin nadir that gives rise to physiological anemia. Therefore, expect the lowest hemoglobin around 2 to 3 months of age, having this between 9 gram per dl to 11 gram per dl. And this is normal. This is physiological, not as a result of iron deficiency. And then we have what we call mean cell volume nadir. That is physiological mean cell volume, nadir. Expect the lowest MCV between 6 months and 2 years of age. Do not over-investigate a mild microcytosis in a well-fed child in this window. Use WHO cutoff point for anemia. For children 6 months to 5 years, hemoglobin less than 11 gram per dl is the diagnosis threshold for anemia. Know the peak and the decline. WBC count and absolute neutrophil count peak at 12 to 24 hours of birth and then fall rapidly. Do not be alarmed by a high WBC count of 25 times 10 raised to power 9 per liter on day 1, but be very concerned by the same value on day 5. The lymphocyte is the king in infancy. The lymphocyte is the king in infancy. From 2 weeks to 4 to 6 years of birth, lymphocytes are the predominant WBC count. From 2 weeks to 4 to 6 years of birth, lymphocytes are the predominant WBC count. A neutrophil predominant differential in a 3-month-old is abnormal and suggests inflammation or infection. Absolute neutrophil count is your best friend when it comes to infection risk in the neonates. The absolute neutrophil count is the single most important number for assessing infection risk in a neonate. Neutropenia is a medical emergency in neonates. And again, presence of left shift, even when the total WBC is normal, is an indication of infection in the neonate. The presence of immature forms, like bad form, on the differential is a crucial clue to serious infection in the neonate. Leukocytosis may not be a strong marker for assessing infection risk in the neonate, but presence of left shift in the presence of leukocytosis, or even when the total WBC count is normal, is a very big red flag in the neonate. It suggests crucial infection going on. Thank you very much for listening to our lecture today. I hope you have learned something. Thank you very much. These are my references. Thank you and thank you.